How easily things go wrong. This is according to George MacDonald in his book, Fantasies. Have you watched the videos?
Yes.
The video, I mean.
Yes.
Okay. Indeed, no surgeon means to operate on the wrong patient, right? On the wrong side of the body, or remove a wrong organ, or perform the wrong operation. But it happens. The training, competence, and good intention of the surgeon, the doctor, the dentist, healthcare professional alone is not sufficient to prevent wrong side procedures. Prevention, therefore, requires an active process by entire surgical team, not only the operating surgeon. Utilizing a standardized peri-operative process designed to prevent such never events. Timeout verification was formulated because it is potentially a key factor in the development of practices and in improving the patient's safety. And as what Mount Faith is saying, one of the goals of the JCI, Joint Commission International, is the goal number 4, ensure correct site, correct procedure, and correct patient surgery. That's why we are mandated to attend this lecture. And my objectives and my goals at the end of my lecture is to define what is timeout, surgical site marking, emphasize the importance of timeout and surgical site marking, evaluate the surgeon or authorized person to do the surgical mark, and to document all of this in the patient's medical record. First of all, I would like to define what is timeout. When we say timeout, it is a time for rest or recreation away from one's usual work. According also to Google Dictionary, this is a brief break in a play or game. But our policy says a verification process before performing any surgical or invasive procedures using patient identification and verification tools. And our policy also saying that the purpose why they make this policy is to ensure patient safety by establishing consistent guidelines in performing pre-procedural verification, correct site marking, and timeout documentation. These three, we will tackle this one by one. I will start with verification. Verification happens in two areas. First, it happens in the receiving area, or what we are saying, the holding bay. In the holding bay, we are checking and verifying the patient identification against ID band, correct site and site marking. Any discrepancies, any problem, please be addressed to the receiving area nurse, and anesthesia and surgical consent. Let us take a look on this consent. Your consent is a legal document, please. Please fill all the blanks. If you do not want to put names in this area, you can just put your patient label. And never ever put your patient label here. Why? Anybody knows? Why we are not allowed to put the patient label here? Yes, Ate?
Because the sticker here is in the right side, patient information and printing card. You should put the sticker there, not in the left side.
Okay, thank you very much, Ate. Very clear, no? This area is imprinting card. We must put the imprinting card in this area, not here, because these boxes are only backup. In case our printer is not working, you can write the patient name the hospital number, the nationality, the company code. Is it clear?
Yes.
Now the mysterious sticker or patient label. Maybe the new staff is wondering why we are putting our stamp and our signature in this mysterious sticker. Why? We are putting our stamp and signature half of the sticker and half of the space provided. Why? Because if you have an enemy in your ward or someone want to remove the sticker is still authentic. The one who identify really the patient, what I mean is the ID number is still there. The sticker is still authentic or original. So you will trace that the sticker is being falsified. And never ever put your sticker with your stamp, with your signature outside the sticker. Why? Why?
Somebody can still change the sticker and it will be under your name. Somebody can still change. Somebody can still change the sticker and the ID number down is somebody else.
Thank you very much. Do not sell yourself into trouble. Do not put yourself into trouble. Because if somebody remove the sticker, your stamp and your signature is still there. And if I want to put another sticker there, who will blame? Who will be blamed? The one being stamped and the signature. And please do not put your stamp and signature over the identifiers. You cannot read anything. On the first verification in the receiving area, we also need to verify the needed equipments. When we say needed equipments, these are your implants. If the implants are available, if there is a need for vacuum, what is this? Vacuum machine for wound dressing, usually the surgical wards. And then if there is a need for x-ray, and of course, the nurse will not bring the x-ray with the receiving area because we have our x-ray inside the operating room. Another thing is the relevant documents and diagnostic results. When we say relevant documents, what are these? These are your old files. The diagnostic results, these are your x-rays from other hospital, laboratory from other hospital. Anesthesia review. Be sure that the patient was seen by anesthesia before pushing the patient into the receiving area unless the anesthetist told to do so, to push the patient because they already seen the investigation in the system. And they know already the NPO time and any things. Blood and allergy, it is important also. Skin prep, elimination status, latest vital signs, and etc. If all of this was being addressed, you can push now the patient into the theater, wherein the second verification and identification happens. In the main theater, we are doing the verbalization or the confirmation of patient identification, correct side marking, perioperative prophylaxis, position, consents by all the entire surgical team. When I say entire surgical team, it contains the surgeon, assistant surgeon, the scrub nurse, circulating nurse, consultant anesthetist if needed, anesthetist, and your anesthesia technician. Any discrepancies, please be addressed again to the room nurse before pushing the patient. The video I am going to show you is an improper way of doing the timeout. And you will notice how different this is in the good way of doing timeout.
Timeout, everybody. Can all team members introduce themselves?
Okay, we don't have time for this today. We're running late.
What's the patient's name?
He is Mohammed Bashir, cholecystics.
Come on, focus here. Focus.
Mr. Murthy, how much blood loss are you expecting?
No, man. This is a straightforward case. Just stick everything.
Antibiotic prophylaxis? Antibiotic prophylaxis?
No, he hasn't had any. Do you want some, Krishna?
You haven't given any yet?
It's a surgical decision. You haven't told me to give him antibiotics.
We always give it augmented. Come on, you're happy to close? Yeah, sure.
Mr. Murthy, can you do the sign up, please?
Hey, man, no problems. Have we sent for the next patient?
Yeah, he's in the anesthetic room.
But
This is the correct timeout.
Good morning. Is everyone ready for the timeout?
Yes.
Mr. Rahman, go ahead, please.
Can you please all introduce yourself?
I'm Abdullah Ansari. I'm the operating surgeon.
I'm Dr. Ahmad.
I'm Sister Justina.
I am Mr.
I'm Sister Ahmed. Mr. Abdullah, can you please confirm the patient name, the procedure, and the site?
Patient's name is Sami Saeed. I'm performing left varicocelectomy, and the site is marked as visible.
Mr. Justina, are you all documents available? Yes, all instruments are ready. Mr. Abdullah, can you tell me what is the expected length of the procedure, and if there is any critical done or can
These routine surgeries will take under 1 hour. There is no critical issue.
Any patient-specific concern?
There is no concern.
Mr. Nick, has DBC medication prophylaxis been given? Is pneumatic pump been applied at the patient? Has antibiotic prophylaxis been given within 6 minutes? Mr. Abdullah, all images are being displayed.
Not necessary for this case.
Okay, thank you.
Thank you. Can we start? Nice, please.
Mr. Abdullah, the procedure being performed is left varicocelectomy. Is that right?
That's correct.
I have a specimen being labeled as passed from the left cord for Mr. Sania Said. Is that right?
That's right.
Do you have any concern regarding the equipment and the instruments?
The scissors is not sharp enough. We'd like to report it.
Okay. All the instruments and the forms are correct.
Thank you.
The skin integrity has been checked and the skin is intact. Dr. Nick, do you have any concern for recovery and for recovery management? Okay, we are done.
Okay, have you seen the difference? What is the difference? You know this? Yes, ma'am?
Yes, there is great difference between both the videos. The first one is totally wrong. They don't have enough time, they're hurried to do it. The second one, they properly think about it and they use their correct time for the time.
Thank you very much, ma'am. Again, ma'am, what have you noticed?
I noticed the first one is very in a hurry to do the procedure, but the second one is all the important procedure. They are checking every doctors. They are telling what is the best way to do.
Thank you, ma'am. You want to give away? Okay, it is totally different. The other one, improper way, is what? The circulating nurse is wearing what? There's no mask. And also the anesthetists at the back, they are talking without mask. And what? They are in a hurry, all in a hurry. No need for the timeout. No need for the antibiotics. There is misunderstanding regarding the antibiotic. See, the anesthetist is blaming the surgeon, or the surgeon is blaming the anesthetist, because the anesthetist said, we are always giving antibiotic, but the surgeon did not tell to give the patient the antibiotic. The next video that I will present is the proposed timeout in our hospital, Royal Commission. This one was embedded in our digital OR, but inshallah, we will use this system. This is paperless. Okay, we will do the timeout. Correct patient identity. Confirmation that the correct site and site are marked. An accurate procedure consent form. Agreement on the procedure to be done. Correct patient position. Relevant images and results are properly labeled and appropriately displayed. The need to administer antibiotics or fluids for irrigation purposes. Safety precaution based on patient history or medication use. Okay, time out complete. Now let us go to the very controversial topic, or surgical marking. For surgical marking, the involvement of the patient and our family is important. The surgeon is responsible for discussing marking with the patient and has the duty of informing the patient the benefits of marking, which help to make surgery safe. Participation of the patient and his or her family help to reinforce the effectiveness of the marking process and should be encouraged. And all the education done to the patient, please put on your PLP form, even the site marking. The site marking you can put on this side. Other, specify site marking. Okay? When to mark? The question is when to mark. Okay. We will mark, sorry. We will mark before patient transfer to the operating theater, and ideally before sedative pre-medication on a patient who is awake or conscious. The question is, who marks? Okay, the operating surgeon should mark the surgical site, and delegation to assistant surgeon or nurse is possible if this person is involved in the operation or is directly involved in the patient preparation process. I think this delegation to the nurse is not applicable in our hospital, only for assistant surgeon. What if the patient refuses marking? What you are doing in the ward?
We will get the refusal form there is, and we will inform the social worker, the doctor, everyone, and we will ask the patient to sign the refusal form. And we will convince the patient.
Thank you very much. Her answer is very concise. Do we need to cancel the case because no site marking? No. Our SOP said it is not required the procedure to be cancelled. And this situation should be handled the same way as for any other refusal by a patient offered care, treatment, or services. The doctor is providing the patient with information to understand why site marking is appropriate and desirable and the implications of refusing the site marking. And please use the preoperative verification checklist and place there refusal form. This is the AMA, against medical advice. You can fill in these blanks. I think site marking will go, Ma'am Faith, medical surgical procedure.
Health instruction and
Health instructions and proposed surgery. Tick all the applies. The characteristics of good marking or the correct marking. The purpose of marking is to identify clearly the site of incision or insertion. Do you think this one is correct?
Not correct.
Correct or what?
No.
No. Because the incision line is here. Marking is carried out at the intended site or as near as possible to the intended site. Unless clinically necessary, no other point should be marked besides the surgical site. What do you mean by this? If the operation is right distal tibia fixation, you should not mark any area, the left or the right, to avoid confusion. Only this area. Do not mark anywhere. Okay? The mark must not be ambiguous. What do you mean by ambiguous? There are different ideas. Interpretation. A cross marking is not applicable because it is telling that do not operate here. But the real fact is this is the surgical area. The mark must be made with a skin marker that is sufficiently permanent to remain visible after preparation of the patient. Even though we did a skin preparation in the OR, the skin marker is still there. And last, in general terms, the type of mark is determined specifically in accordance with the wishes of each organization on the basis of a formalized and harmonized marking procedure. Some institution is using this one. Some institution is this one. And our institution is using this one, the last one. What about if dark complexion patient? What you are doing? No offense,
We need to use mark that will be easily seen or recognized. For this one, can you use
So I will use white. Let us try this one. This marking. Can you see the marking?
No.
The other institution is proposing to do this way. You will put a plaster on the operative site, and then you can do the marking and put the initial over it and put the intended procedure. Also, put the patient label to be sure. Okay? Which site to mark? This is the very controversial one. We will mark all areas of the body with laterality. When we say laterality, we have left and right. Your eyes, your foot, your feet, your hands. Multiple structures. Your fingers, your toes. What about the spine? Levels. We need to do marking. There are also exceptions to marking. If there is a life-threatening emergency patient, please do not tell me that I cannot push the patient because there is no marking. But the patient is heavily bleeding on his foot. The patient will die not because of the heavily bleeding, but because of no site marking. The other one is premature infant. Who is from NICU here? NICU? NICU?
Can I say your staff?
Of course, they will not raise hands. Why we should not put permanent marker on the premature infant, because this permanent tattoo, permanent marker will make a tattoo and cannot be removed in the infant. Next, for any dental procedures, who went surgery for the tooth and mark on the tooth itself. Then endoscopic procedures, not needed also. And then all wounds, please, if there is obvious wound, which is single wound, no need for site marking. Unless the wounds are multiple. What about this? We need? No need. We need because there is multiple. And then all areas with bilateral. No need. If the procedure is bilateral injection, bilateral removal, no need. And those laterality are not confirmed. These procedures are the diagnostic laparoscopies. For example, ovaries, even the CT scan, the MRI, the ultrasound cannot determine if it is right or left. So they need to do open surgery. Now, let us evaluate. Who wants copy? Nobody wants copy? For tonsils, tonsillectomy, do we need any marking? No? What about appendix? Appendix.
No need.
What about marking on the cast? Is this right or wrong? From male ortho, Gigi.
It's wrong. It's wrong. It should be
Wrong?
Yes. Because we will cut them. And it should be
Wrong?
Yes.
Marking on the cast is acceptable, ma'am. Because we cannot remove the cast.
But it should be above, no?
If you remove the cast and you do the marking,
No, we will
the
not
bone will
remove.
displace.
We will not remove the cast. Above there.
No, the
arrow will be there.
But
it should be visible after the skin preparation.
Yes.
Before skin incision, we will remove the cast. That means it's not correct.
okay. But if the operative site is the whole area, the whole hand.
Yes.
Okay, next. Left hemitherectomy. We need marking or no?
Right, left, it's needed.
Ma'am natin siya. Okay, we need, how many thyroids we have? 2. The left and the right. Ma'am Nadia wants copy also. The operation is ORIP, left third distal interphalangeal joint. Very difficult, no? So, what is your idea? Do we need, this marking is correct or no?
Yes. Need to mark.
You don't like copy. When we say fourth distal interphalangeal joint, this is the area. We have distal, interphalangeal, intermediate, proximal, metacarpal, and carpal. So, this is what? Proximal interphalangeal joint. So, this is wrong. What about left foot wound debridement? We need? Okay, no need. Any wound? No need for site marking. What about this? Bilateral injection of placentis? No need also. But some surgeons are putting the marking for to make it sure. What about this? Bilateral amputation of second toes. I think the problem marking is not the site marking. The toes. We need to do. We need to do. Why? Who knows where is the first digit and the second digit? So to avoid confusion, we have to do the marking. There are special cases also for marking, like spinal surgery. Spinal surgery procedures needs two marking. Before you push the patient in the receiving area, there must be a mark on the back, and inside the OR they are doing marking guided with the X-ray. For laparoscopic, minimally invasive procedures, they are doing marking also beside the main insertion site like this, right ovarian cystectomy. To avoid confusion, they are doing the marking on the intended site, like left ureteroscopy, TJ insertion. To avoid confusion also, they are putting marking on the operative site. What about this non-palpable lumpectomy? They are doing harpoon marking. When we say harpoon marking, there is a metal with a tie. This is guided by your ultrasound or your CT scan. This is the usual marking. We can do also this one, but this one is for palpable lumpectomy. And finally, the timeout documentation. All the process being done, the verification and the identification was documented in this pre-operative checklist. I just want a suggestion that in the operative site mark area, please put the surgeon who did the site marking, because there are too much JDA, MM, Muhammad in this hospital. And if the patient refuse site marking, please put on the remarks, refuse. And then in here, the surgical safety checklist, this is for operating room nurse, and this one also. And as a summary of my lecture, I want to show this video.
Receptionist check all theater list and confirm the readiness of the theater and patient. On arrival of the patient, the nurse receptionist and the ward nurse uses the ISPAR2 law endorsement. The receptionist asks the patient for identity and on the things that will affect surgery. Confirms with the ward nurse the surgical checklist. Patient identification, procedure site, consent, site marked by person performing the procedure, history and physical assessment, pre-anesthesia assessment, diagnostic and radiological test results, blood products, any special equipment, devices, implants. Sign-in will be done in holding. The holding area will use the ISBR tools to endorse the patient to theater nurse. Sign-in will be done by attending anesthetist and theater nurse. They will double-check the previous items in surgical checklist and they will sign the record. After anesthetizing the patient and before the skin incision, the surgical team, the nurses and surgeon and anesthetist will verify and confirm the following. Patient site identification. Procedure. Site marked and visible. Patient's position. All team members should present and attentive. The nurse asks if antibiotics prophylaxis given within 60 minutes. Implants available. Duration, blood loss, instrument, sterility. Sign-out will be completed before the patient leaves the operating room. The surgeon will confirm the name of procedure, any specimen taken, and the nurse will confirm the completion of instruments, sponges, and needles. Patient safety is our priority. Safe surgery, save lives.
And therefore conclude, if duty is life, work is life, time out is life also. Do it seriously and professionally by heart, because patient safety is our responsibility. Thank you very much. Any question? Please ask Google.
Thank you so much, Sir Johnny. Do you have any questions, clarifications? Thank you. I want